what if the exact same cosmetic tool used in Beverly Hills to, smooth out crow's feet and tighten jawlines is actually the key to reversing one of the most painful, chronic, and just totally misunderstood dermatological conditions on the planet?
Yeah, it sounds a bit wild when you first hear it, but the clinical implications here are they're massive.
Right, because for anyone tuning in who follows chronic dermatology, the treatment landscape can often feel really, well, stagnant. The protocols rarely change, and breakthroughs are, few and far between.
Absolutely. But today, we're looking at a genuine paradigm shift. We're talking about a complete mechanical rethinking of how medicine enters the body.
Exactly. So our mission for this deep dive is tackling a core question.
Mm.
Can automated microneedling combined with topicals improve drug delivery in hyperkeratotic lichen sclerosis?
It's such an important question because we're shifting the focus from, simply managing the symptoms of a disease to actively remodeling the structural damage that it leaves behind.
And to figure this out, we have an incredibly robust stack of sources to go through today. We're pulling from the current baseline dermatological guidelines on lichen sclerosis, a really fascinating clinical study from the Journal of Cutaneous and Aesthetic Surgery, deep data from retrospective aesthetic medicine clinic studies, and some highly advanced, almost sci-fi level research on cosmetic microneedle delivery systems from newsmedical.net.
It's quite a stack.
It is. And guiding us through all the complex pharmacology and cellular biology is our resident calm voice of reason.
Well, I'm glad to be diving into this one with you. The stakes for the patients dealing with this condition are incredibly high, and, exploring how technologies cross over from aesthetics to severe chronic pathology is always a really revealing process.
Okay, let's unpack this, because before we can really look at how the cosmetic tools come into play, we need to clearly establish the physical barrier we're dealing with when it comes to lichen sclerosis, or LS for short.
Right. And most of us familiar with LS know it as this chronic inflammatory condition, typically affecting the genital and perianal areas.
Yeah, characterized by intense itching and really significant architectural changes to the anatomy over time.
Exactly.
Yeah.
But there is a specific manifestation we are focusing on today, which is hyperkeratotic LS.
And I think there's a common misconception here. Because LS skin tears and fissures so easily, a lot of people just assume it must be, paper thin and delicate.
Yeah, that assumption is highly intuitive, right? Given the visible fragility of the tissue.
Sure.
If something tears easily under, minimal friction, we generally assume it's thin. However, in hyperkeratotic LS, it's actually the exact opposite happening.
Wait, so it's not thin at all?
No, not in this variant. Hyperkeratosis refers to a profound thickening of the stratum corneum, which is the outermost layer of the skin.
Okay.
So the skin is tearing not because it's delicate, but because it has completely lost all of its natural elasticity.
Oh, wow. I actually found a quote in the clinical guidelines from Dr. Kraft that illustrates this perfectly. She describes hyperkeratotic LS skin as being, quote, like a thick sidewalk of concrete cracking. She says there's no give to the tissue, unquote.
That visual is perfect. The concrete sidewalk captures the clinical reality of the tissue exactly.
Because the autoimmune inflammation is basically raging in the deeper dermal layers, right? But the top layer has just turned into this rigid and flexible wall.
Exactly. It cannot expand. It cannot accommodate daily movement or physical friction. So when it's subjected to, just normal biological stress, the tissue simply cracks.
So keeping that cracking concrete sidewalk in mind, the sheer frustration of the current first-line treatment protocol, it starts to make a lot of sense.
Oh, absolutely.
If you were diagnosed, the standard of care relies heavily on ultra-potent topical corticosteroids, like clobetasol 0.05%, or sometimes calcineurin inhibitors like tacrolimus.
And to be fair, the drugs themselves are highly effective at suppressing that localized overactive immune response.
Right. The pharmacological mechanisms of those topicals are well established. They absolutely shut down the inflammatory cascade.
Yeah. The bottleneck in the treatment isn't the medication at all. It is the physical delivery of the medication to the actual target area.
Which makes sense, because the delivery mechanism sounds physically exhausting for the patient. The guidelines often suggest patients soak in a warm bath for 15 to 20 minutes just to artificially hydrate and soften the skin, attempting to open the pores.
And that's just step one.
Right. Then they are instructed to take a pea-sized amount of this potent ointment and aggressively rub it into the affected area for up to 2 minutes.
Which is an incredibly long time to be rubbing damaged tissue.
Exactly. I mean, you are asking a patient to forcefully rub an ointment into skin that is already tearing, fissured, and deeply painful every single day.
It's a massive adherence hurdle. Patients experience extreme discomfort just trying to comply with the basic medical instructions.
But it also seems like biochemically inefficient. If this skin is as thick and flexible as cracking concrete, how much of that steroid cream is actually getting where it needs to go?
Well, that brings up the 500 Dalton rule in pharmacology.
Right, I saw that in the sources. What exactly does that mean?
So we know that molecules larger than 500 Daltons, which is just a measure of molecular weight, they already really struggle to penetrate an intact stratum corneum.
Oh.
So these high molecular weight topicals are basically just sitting on the surface.
It feels a bit like trying to get rainwater to nourish a root system underneath a heavily paved parking lot.
That is exactly it. It gets right to the core of the passive diffusion problem. Conventional creams and ointments, they rely entirely on a concentration gradient to push the active ingredients down into the tissue.
And even on completely healthy, normal skin, passive diffusion is pretty inefficient, right?
Highly inefficient. So when you attempt passive diffusion on hyperkeratotic, heavily scarred tissue, only a microscopic fraction of the active ingredient ever actually reaches the viable epidermis and the fibroblast-rich dermis, which is where the inflammation actually originates.
So we basically have a fundamental delivery failure. The drugs work, but they are locked out by the architecture of the disease itself.
Exactly.
And this is where I start getting really interested in the crossover from aesthetic medicine.
Right.
Because the solution to bypassing this barrier isn't some new chemical formulation. It's entirely mechanical.
Right.
We're talking about automated microneedling.
Yes. Microneedling, which is formally known in the literature as percutaneous collagen induction therapy, has a very long history in aesthetics.
Like for treating acne scars, striae, and for general facial rejuvenation. Right.
Exactly. The premise is utilizing microscopic needles, usually somewhere between 150 to 1,000 micrometers in length, to physically puncture the stratum corneum.
Now, I want to clarify something from the sources here. Because when a lot of people hear microneedling, they picture those manual dermal rollers you can buy for like $20 online, you know, the little handheld wheels covered in needles.
Right, the rollers.
But the clinical applications we are looking at exclusively use automated microneedling pens. I was looking at the mechanics of these pens, and the difference is crucial, isn't it?
It is entirely different. With a manual roller, because the needles are on a wheel, they enter the skin at an angle, they reach their maximum depth, and then they pull out at an opposing angle.
Which creates this sort of dragging or tearing motion through the tissue.
Exactly, which you definitely don't want on fragile skin.
Yeah.
The automated pens completely eliminate that lateral trauma. They use a motorized system to rapidly stamp the needles in and out in a perfectly vertical trajectory.
So it's like thousands of micropunctures per minute without any of that dragging.
Thousands. Additionally, the practitioner has precise control over the depth of penetration and the oscillation speed, so they can adjust it on the fly depending on the thickness of the specific tissue they're treating at that exact moment.
It goes right back to that paved parking lot analogy for me. If passive diffusion is just, pouring water on concrete, the automated pen is essentially a microscopic industrial aerator.
That's a great way to think about it.
You are physically punching thousands of uniform microchannels straight down through that hyperkeratotic stratum corneum. It's like you're aerating a compact lawn before you seed and fertilize it. You're creating direct vertical tunnels to the root system.
Yes. And once those channels are open, applying a high molecular weight compound, whether it's the clobetasol, the tacrolimus, or something highly regenerative like platelet-rich plasma.
It means the drug doesn't have to fight its way through the barrier anymore.
Right. It simply bypasses the concrete entirely. And what's fascinating here is the transient nature of these microchannels.
What do you mean by transient?
The dermatological delivery studies show that these specific pathways actually close within a few hours of the procedure.
Oh, really? That fast?
Yeah. So you achieve this localized, massive spike in bioavailability for the applied drug, but the barrier quickly seals itself back up.
Oh, I see.
That rapid closure is vital because it prevents excessive transepidermal water loss and significantly mitigates the risk of secondary infections or prolonged irritation.
So the daily, painful ritual of rubbing steroids into tearing skin could potentially be augmented or even replaced by clinical sessions where the drug is guaranteed to reach the target tissue.
Exactly.
But as I read deeper into the Journal of Cutaneous and Aesthetic Surgery source, I realize the drug delivery is almost a secondary benefit. The physical act of driving those needles into the skin triggers something else entirely.
It really does.
Though I have to admit, I got really stuck on this part of the study, because you're taking a motorized bed of needles to skin that is already tearing, ulcerated, and deeply traumatized by LS. My first instinct was, honestly, that this sounds like a medieval torture device for someone with this condition.
Oh, sure.
Like, how does that localized trauma not just trigger a massive, catastrophic inflammatory flare-up?
The hesitation is completely warranted when you're looking at any inflammatory disease. It's totally counterintuitive at first glance,
Right.
but the key distinction lies in the physiological nature of the trauma. Chronic, low-grade trauma, like continuous scratching or the micro-tearing from daily movement, that sustains the disease cycle.
Okay, that makes sense.
Automated microneedling, however, creates highly controlled acute micro-injuries. This acute injury effectively overrides the chronic inflammatory state by forcing the localized microenvironment to shift immediately into an active wound-healing cascade.
It basically forces the tissue to reboot. The micropunctures trigger an immediate release of growth factors deep in the dermis. The sources specifically highlight fibroblast growth factor, transforming growth factor, and platelet-derived growth factor. So that's FGF, TGF, and PDGF.
Yes. Those growth factors are the primary signaling proteins that activate the dermal fibroblasts.
Which are the cells that build the structure, right?
Right. In a chronically scarred environment like hyperkeratotic LS, the fibroblasts are essentially dormant. They're just surrounded by rigid, poorly organized collagen.
So the acute injury signals those fibroblasts to wake up and begin neocollagenesis and elastogenesis, which is just the synthesis of brand new, correctly aligned collagen and functional elastin fibers.
Exactly. The needles physically break up the concrete architecture of the bad collagen, and the resulting growth factors instruct the body to lay down fresh elastic tissue in its place.
And the clinical evidence for this mechanism is really compelling. The Journal of Cutaneous and Aesthetic Surgery study looked at a patient with facial blasco-linear lichen planus.
It's a rare condition, for sure.
Yeah, but it shares the exact severe hyperkeratotic and atrophic scarring features we see in advanced LS, right?
It does, and the parameters they use in that specific case study are highly illustrative of the mechanical thresholds required.
What were the parameters?
The practitioners utilized an automated microneedling pen set to a really deep depth of 2 millimeters, performing 10 consecutive passes over the severely scarred tissue.
Wow, 2 millimeters and 10 passes? That is an intense level of mechanical disruption for the tissue to handle.
It is. They proceeded until they achieved pinpoint bleeding, which is the necessary clinical endpoint confirming they had successfully penetrated the scarred dermis and actually reached the vascularized tissue beneath.
Oh, I see.
The sustained, repetitive puncturing physically sheared and disrupted the fibrotic dermal collagen that was anchoring those scars.
And the results were pretty amazing, right?
Incredible. Over the course of the 18-month follow-up period, the patient demonstrated profound aesthetic and structural improvement. The newly synthesized collagen matrix completely restored the skin's flexibility, and the patient remained entirely disease-free without the need for constant topical suppression.
So when you apply that same logic to lichen sclerosus, the synergy is undeniable. You are attacking the pathology from two completely different angles simultaneously.
A double whammy.
Yeah. The mechanical action of the microneedling shatters the hyperkeratotic barrier and jumpstarts the production of healthy elastic tissue. And in that exact same window, the open microchannels perfectly deliver the heavy-hitting therapeutics.
Right down to where they are needed.
Exactly. Whether it's the standard corticosteroids to aggressively extinguish the remaining autoimmune fire, or biologics like PRP.
Yes, platelet-rich plasma.
Which is actually FDA approved for LS and is completely loaded with its own concentrated growth factors, which you are now dropping directly into the fibroblast-rich dermis.
It creates an environment where the medical and mechanical interventions just amplify each other completely.
But here's where it gets really interesting for me. Because breaking the concrete and delivering the drugs is a massive leap forward. But the aesthetic medicine sources reveal they are actually tackling a secondary problem: tissue laxity and deep structural remodeling.
Yes, they took it a step further.
They didn't just want to break up the scar tissue. They wanted to, shrink wrap and deeply regenerate the underlying connective tissue. And to do that, they added heat to the needles.
Right. This brings us to the utilization of radiofrequency, or RF, microneedling. The technology has been heavily popularized by devices like Morphe-V and Forma-V in the aesthetic and gynecological spaces over the last few years.
I was looking at the Morphe-V specifications, and what blew my mind is the engineering of the needles themselves. They are insulated or coated along the entire shaft with only the absolute tip left conductive.
That's the secret to it.
So when they penetrate the skin, you aren't burning the epidermis at all. You are completely bypassing the surface and deploying a targeted burst of heat straight into the deep subdermal layers.
The precision of that energy delivery is exactly what makes it viable for compromised, sensitive tissue, like in LS.
How adjustable is it?
Highly. The practitioner can adjust the penetration depth, often 1, 2, or 3 millimeters, and deliver directional radiofrequency energy that generates subnecrotic heat. We are talking about maintaining a highly specific temperature window, typically between 40 to 45 degrees Celsius.
And subnecrotic meaning you aren't vaporizing cells or causing third-degree burns inside the tissue.
Quite the opposite, actually. At 40 to 45 degrees, the heat safely coagulates localized fat and forces an immediate violent contraction of the existing connective tissue network.
Oh, wow.
Yeah, the damaged, elongated collagen fibers instantly shrink and tighten. Simultaneously, that thermal shockwave initiates a profound secondary healing response, accelerating neocollagenesis and prompting angiogenesis.
Angiogenesis, which is the formation of new microscopic blood vessels to restore blood flow to the ischemic tissue, right?
Exactly. You're bringing fresh blood supply back to an area that was starved of it.
So you get this incredible compounding effect. The mechanical disruption from the needles, the creation of the drug delivery microchannels, and a deep thermal shock wave that forces the tissue to rebuild its structural integrity.
It's remarkably comprehensive.
And the clinical data on this specific combination for lichen sclerosus is arguably the most exciting part of this whole deep dive.
I agree completely.
Let's look at the retrospective study published by Evolve Aesthetics. They tracked 33 women suffering from moderate to severe LS. And the most critical detail about this cohort is that this was a refractory group.
Right, which means these 33 women had already failed traditional clobetasol treatments.
Yeah, the standard creams were either no longer working or they never worked to begin with. They were completely out of conventional options.
Treating a refractory population is really the ultimate stress test for any new modality. These patients underwent a protocol utilizing this specific RF microneedling technology. They received just 3 treatments, appropriately spaced out by 4 to 8 weeks, to allow for the collagen remodeling phases to fully occur.
The results they documented are just staggering to me. Following just those 3 treatments, 86% of the women in this refractory group reported significant or complete resolution of their common LS symptoms.
Which is huge, and breaking down the specific symptomatology reveals the true impact on their quality of life. For itching, which is notoriously the most relentless and, sleep-disrupting symptom of LS, 91% of the patients experienced significant or complete resolution.
91%. 91% of patients who had previously failed standard steroid therapy finally found relief.
Yeah.
And the most definitive statistic from the entire study was that 55% of these patients experienced complete 100% resolution of all vulvar LS symptoms. Over half the cohort got their baseline tissue health and effectively their lives completely back.
If we connect this to the bigger picture, this represents a fundamental paradigm shift in chronic dermatology. For decades, the entire philosophy for managing autoimmune skin conditions has been strictly suppressive.
Right, just trying to pause it.
Exactly. The goal was always to use topical agents to suppress the local immune system, to stop the body from actively destroying itself, and hopefully maybe slow the progression of the scarring.
But this RF microneedling approach isn't just suppressive, it's actively regenerative.
We are moving beyond just holding the disease at bay. By physically breaking down the fibrotic plaques, restoring vascularity through angiogenesis, and forcing the synthesis of new elastin and collagen, we are giving the tissue the specific mechanical and thermal signals it needs to literally reverse the architectural damage.
So what does this all mean for you, the listener? Well, this deep dive reveals that the frustrating, painful reality of managing a chronic hyperkeratotic condition like lichen sclerosus doesn't have to rely solely on the exhausting daily routine of rubbing potent creams into an impenetrable barrier.
Hoping passive diffusion will somehow, magically defy the 500 Dalton rule.
Exactly. Automated microneedling, and particularly the addition of targeted radiofrequency, provides a physical-mechanical bridge. It ensures crucial topicals are delivered directly to the dermis, bypassing the concrete entirely.
While simultaneously coaxing the damaged skin to remodel, vascularize, and heal itself from the inside out.
It's amazing. But I know you wanted to touch on one more thing before we wrap up.
I do, because the convergence of cosmetic technology and chronic disease management we are seeing today is really just the beginning. I want to leave you with one final thought based on the research from newsmedical.net regarding the future of cosmetic and medical delivery systems.
This is the sci-fi part.
It is. The horizon extends far beyond automated metal needles. Researchers are currently developing microscopic patches utilizing smart, stimuli-responsive polymers.
I read that section and it feels like pure science fiction. The needles themselves are actually made of active polymers.
Yes. The underlying science relies on a rapidly approaching future where a virtually invisible, painless microneedle patch is applied directly to the LS-affected skin.
Okay.
It remains there, completely passive, but the polymers are designed to continuously sense the local biochemical microenvironment. If the patch detects a sudden drop in the tissue's pH or a localized spike in temperature, both of which are the very earliest biochemical indicators of an impending inflammatory flare-up.
Wait, so it would sense the physiological changes of the flare before the patient even registers the first itch?
Exactly. It neutralizes the inflammatory cascade before the clinical symptoms even have a chance to manifest. The moment the polymers sense that specific trigger, the needles automatically dissolve.
Oh, wow.
And by dissolving, they release a precise microdose of a calcineurin inhibitor or a biologic directly into the dermis.
That makes total sense. It completely transforms dermatological care from this reactive scramble, waiting until the tissue is tearing and you're in pain to start applying ointment.
Right.
It changes it to a completely proactive autonomous defense system. It's like having a microscopic specialist embedded in the tissue, monitoring the microenvironment 24 hours a day and intervening the exact second things go wrong.
This raises such an important question about how we view treatment timelines altogether. It is the ultimate evolution of personalized, high-performance medicine. We are moving from treating the damage to preventing it entirely.
That is a profoundly optimistic place to land. From the grueling reality of aggressive ointments on a cracking concrete sidewalk to a future where a smart, invisible patch quietly tends to a healthy, elastic tissue matrix. Thank you for joining us on this deep dive. Keep questioning the standard routines, keep exploring the boundaries of the science, and we'll catch you on the next one.